Episode number 239 of the Wholesome Fertility Podcast. My guest today is Danielle Cheplowitz. Danielle is a board-certified adult nurse practitioner and a certified functional medicine practitioner through the Institute for Functional Medicine. Danielle began her medical practice in a conventional primary care setting in 2014. After experiencing fertility challenges firsthand, she discovered the functional medicine practice model and never looked back. Danielle now works with fertility clients through a functional medicine lens and advocates for general health optimization. She is passionate about supporting each client on their own health and wellness journey. Welcome to the Wholesome Fertility Podcast. I'm Michelle, a fertility acupuncturist here to provide you with resources on how to create a wholesome approach to your fertility journey. Welcome to the podcast, Danielle.
Thanks so much for having me, Michelle.
It's great to have you on, and I would love if you could introduce yourself to the audience.
Absolutely. So my name is Danielle Cheplowitz, and I am a certified adult nurse practitioner. I was certified back in 2014. And since that time, I have gotten into the functional medicine arena within my scope of practice. And so I was certified as a functional medicine certified practitioner as well.
Awesome. And then I know that you've also had your own fertility challenges that got you into this. Has that helped you as well?
Yes. So I was conventionally trained as a nurse practitioner, and I was working in a regular primary care environment, was going through my own fertility challenges. I thought that, being trained as a nurse practitioner, I would have enough insight to treat myself, and became very frustrated when I realized I did not have the tools to figure out why I was having trouble conceiving. Took several years and, finally going to a reproductive endocrinologist, and we went that whole route. Initially, unfortunately, we ended up with a pregnancy loss. And I think stemming from that whole experience kind of transformed me a bit and led me into the more natural, holistic route. My eyes opened to a whole nother area of healthcare that I didn't know existed. And I was just so grateful, honestly, for the opportunity to start to learn this new way of practicing. And so I fell in love with it. And ever since 2019, I've been practicing in a slightly different way where I look at the whole patient, the whole person, and all of the bodily systems that come together to create, this one unique being. So yeah.
And I know that a lot of people listening have heard of functional medicine, and I've had people come on that practice functional medicine, but just to kind of break it down for people who are like, okay, I've heard about functional medicine. What exactly is it? What does it encompass? And like, how does it work?
Absolutely. So the functional medicine model, it's an individualized patient-centered science-based approach, and it basically empowers the patient and the practitioner to work together to address these underlying causes of disease, and it promotes optimal wellness as well. So it requires a detailed understanding of the patient's genetic, biochemical, lifestyle factors, all kind of incorporated into one. This data then helps to create treatment plans specific to the individual. These personalized plans will lead to much better patient outcomes, as well as leaving the patient feel like they are heard, and that all of the different aspects of their health are addressed, very much so. So, yes.
I personally love it, and I think it's amazing, and it does make a difference. It's a little bit more intricate. So you talk about testing. Usually with labs, there's testing, but the ranges are kind of it's more generalized for
Yes.
every person. It's the same, pretty much. And with functional medicine, it kind of gets into a little bit of a lot more of a deeper level, looking into the function of the body, which I love.
Right. And a lot of people are confused about, what functional medicine is, and they almost kind of think that it's like pseudoscience, but It's actually very scientific, and exactly what you said, it really kind of narrows down and breaks down all of these small pathological and biochemical reactions in the body, stuff that scientists have known for a long time. It's just knowing all of the intricate details of that can really, change someone's outcome just by starting small and looking for the root cause, and looking upstream is what we say, is figuring out where it all kind of started and trying to go back and treating it from that really small level. So it's, yes, very scientific and very detailed.
Yeah. So we spoke in the pre-talk about the menstrual cycle and ovulation and the different conditions that sometimes can be confusing for people to really understand, like, why am I not ovulating? Am I ovulating? So would love to talk about that, because I think that there's definitely a lot of myths about it, and a lot of people don't really understand like what can cause them to not ovulate. So would love to
Sure.
break that down. Yeah.
Absolutely. So when someone comes to me and they are having trouble ovulating, whether it's oligomenorrhea, meaning that they have infrequent periods, meaning usually infrequent ovulations, or amenorrhea, where they're not having any bleeds, meaning no ovulations at all. Um, I have a couple of things that I'm thinking about first. So I first want to kind of rule out some of the easy targets. Um, Definitely checking for thyroid conditions. As we know, hypothyroidism can certainly delay ovulation, inhibit ovulation. High prolactin, hyperprolactinemia, which is a hormone that comes from the pituitary gland, and it's known as kind of like our lactating hormone. But when this level can be elevated, it inhibits ovulation as well. So ruling that out. Causes of hyperlactin, it could be a mass on the pituitary, so a little mass or a larger mass, but even something very small can increase that level. Also, I've seen generalized inflammation can also disrupt it, or hormone imbalances elsewhere can also disrupt that level as well. But that would be important to rule out. Certainly looking for some genetic causes, making sure that someone doesn't have something called congenital adrenal hyperplasia, where they're making excess amounts of cortisol, which can also throw off the brain signaling to ovulate as well.
Mm-hmm.
And then certainly, looking at early menopause, which is not very often that I see that in my younger reproductive patient population. It is, I think they say it's 1 in 100, where someone would present with signs of that, which would look like elevated follicle stimulating hormone and elevated luteinizing hormone, FSH and LH. So looking at those things initially can just kind of help me at first. And then I like to kind of differentiate. Once I've ruled that out, I will kind of then play around with, is this polycystic ovarian syndrome, which is this, broad overarching category that I think needs to be redefined, but that it is what it is. And then something called hypothalamic amenorrhea, which is also known as hypothalamic hypogonadism, or relative energy deficiency in sport. So it's kind of known by those three names. So deciding between the two as a practitioner, I'm first looking for a couple of different things that might kind of point me towards a PCOS diagnosis. I will first preface that hypothalamic amenorrhea is often known as a diagnosis of exclusion. So you're really kind of ruling out a lot of different conditions before you can eventually kind of say, this is perhaps hypothalamic amenorrhea. Mm-hmm. But for PCOS, we're looking for high androgens, whether that is on blood work. High androgens would mean high testosterone, high DHEAS. Also clinical signs, hirsutism, which is the excessive facial hair growth, and not just a couple hairs, a lot of facial hair would constitute as that. Sometimes practitioners are using, or acne is part of that androgen excess diagnosis inclusion criteria as well. So high androgens is one. And then, of course, everyone knows polycystic ovarian syndrome and they think of cysts on the ovaries, but part of the Rotterdam criteria, it does include cysts on the ovaries. And then the third one would be, of course, this, lack of ovulation, menstruation, or no ovulating or menstruating at all. So there's three criteria. And so to diagnose polycystic ovarian syndrome, it is advised that someone would have two out of the three criteria to meet that diagnosis. Now, personally, I think that this can get a little hairy because I have seen patients that do somewhat meet this PCOS diagnosis, but really, in fact, they have hypothalamic amenorrhea.
Mm-hmm.
So it does take a little extra digging to really kind of, get the correct diagnosis. And so how I would do that as a functional medicine provider is, of course, digging a little bit deeper, but maybe some of the specific differences between the two. I think one of the most common is that you will see women are prescribed something called a progesterone or progestin Provera challenge, where they are given a certain amount of progestin, this synthetic progesterone, for a certain number of days, usually 10, and then they will stop to see if they have a withdrawal bleed. What the provider is looking for is bleeding, which would indicate that there's estrogen to make the endometrium thicken. So what I'm often looking at as a provider is, what is this woman's estrogen level? So usually a day 3 estradiol. A lot of times you'll see that in patients with hypothalamic amenorrhea have very, very low estradiol levels, whereas the woman with PCOS would have more normalized or maybe even slightly higher, depending on the person. So looking at that estradiol is super important as well. Another interesting marker that I would also look at that's not really part of the Rotterdam criteria would be the LH, the luteinizing hormone. Mm-hmm. And so the LH, this is the hormone that is secreted from the pituitary in the brain, and it's really important for ovulation because when that surge of LH happens, that is what signals to the ovaries to then release this mature egg from the follicle. And so in PCOS, unfortunately, women can have these slight elevations of LH. Sometimes they might even have very high levels of LH. And so when you have this, slightly elevated LH or even higher LH, then ovulation over time can become inhibited because the brain wants to see these great fluctuations in the hormone, not a constant high level of it. It almost kind of gets used to seeing this level, so it doesn't see it as an important reading, so therefore then it won't tell the ovaries to release an egg. So I will often look to see if a woman has PCOS, if that LH level is elevated. Usually with hypothalamic amenorrhea, I will see the LH is very low. So those are, another couple differences. And I also want to make the point that you can have PCOS diagnosed, I think, correctly, and still have a normal LH. So just because you have a normal LH does not rule out the PCOS diagnosis, but it does help to differentiate potentially between the two when you're looking at, some of these more expanded markers. Now, there are types of PCOS that I'm sure you've covered on previous podcasts, but just to kind of overview them, the most common one would be the insulin resistant PCOS, where you will see that the woman has a high insulin level. So the insulin level is elevated, making them more insulin resistant. And so when insulin is elevated, that will create extra androgens in the body and inhibit ovulation. So that's a very common type of PCOS that I see most often. And then certainly we have some other forms. There is something called the inflammatory PCOS, where there's a lot of inflammation in the body. The body will see that there's some sort of stressor going on. So in my mind, functional medicine here is excellent for this type of PCOS because when we see markers of elevation in the body, we have to think, well, what's causing the elevation? Not like, let's just force ovulation to happen. let's see, maybe can we try and reduce this inflammation, take some of it away to see if then that restores normal ovulation. Because if we have, less inflammation, then of course our eggs will be healthier, our endometrium will be healthier, everything will be healthier and working more optimally. So from a functional medicine standpoint, I often get pretty excited when I see a patient that, has some sort of inflammatory PCOS, just because I feel like a lot of times the allopathic conventional side doesn't really know how to manage this type of patient quite as well as they do with the insulin resistant patient. It's much easier to, give a patient metformin or educate on, glucose management than it is conventionally to try and fix someone's inflammation unless you're trained to do so.
Right.
So that's a one that I love to work with personally. Now, adrenal PCOS is another type where the patient is experiencing a lot of adrenal elevations. Their hormones are high, so this might look like cortisol, DHEAS, and again, it's very similar to the inflammatory in a way because we're trying to think, well, okay, we have these high elevations in the cortisol or DHEAS. Someone or something in the body is being stressed out from some reason. We don't know why. So we need to dig to find the underlying cause of what's, driving these elevated adrenal markers. And so again, if you were to, force elevation or force ovulation with certain medications to try and get the body to ovulate, you're still not addressing the adrenal piece. So I think it's helpful to try and figure out what is driving those adrenal hormones in the first place. So again, those are the three different types of PCOS that I typically see. There has been discussion on shades of PCOS with the post-birth control syndrome. I usually counsel patients that it's something that is more like a transition from the birth control pill, and usually it does self-resolve eventually with the assistance of some support, whether that's nutraceuticals, lifestyle changes. It can help someone kind of bridge from that, but that's also can be seen by some practitioners as another fourth type of PCOS. I'm mainly focusing on the first three because I often kind of find that post-birth control PCOS is actually usually kind of categorized in one of those three options anyway. So if I were to dig a little deeper. So those are the three PCOS types that I generally see.
And when you said high cortisol, that's like one of the things that you see now. Is that more something that people can have emotionally, just with life, just like lifestyle, controlling the stress?
Absolutely. Yes. When I see a patient with high cortisol, I'm thinking a couple different things. And from a functional medicine perspective, I in my brain, I have this whole matrix that we work with, and I'm really heavily focusing on the mental, emotional, piece of that because yes, what we think, our thoughts, will then create an emotional response in the body. So whether that's thoughts that we think ourselves, thoughts that are kind of stemming from an outside person, thoughts of, how we're interacting with our environment. So maybe our work or, any situation that can create a, physical response of stress in the body. Yes, it causes elevated cortisol. And so if you're thinking about, maybe what some of these stressors are from, if you're being exposed to them every day, you're going to have elevations in those stress hormones every day. Now, what can happen is that over time, the body wants to protect itself. And so it almost adapts to those high stress levels. And so by doing that, first we'll have this high cortisol and then high DHEAS. And then cortisol, it can be very useful in the body. Obviously, we need it to live, but for long periods of time, it can put a lot of stress on our organs. And so our body tries to, dampen that cortisol level and keeps the DHE as high. And so then over time, we're kind of like downshifting a little bit. And then finally, one of the more later stages of adrenal dysfunction, you'll kind of see almost like a flat line. If you were to get a sample of someone's saliva over 24 hours, you would see this just flat line, horizontal line, whereas you want to see a diurnal curve in a typical normal, individual where that cortisol level spikes in the morning and then it kind of gradually goes down and levels off. So with adrenal PCOS, I'm definitely looking for high cortisol levels, but I'm also looking for the patient that has suboptimal levels. Um, some conventional providers will argue that, well, adrenal dysfunction doesn't exist, and it's either Cushing's or Addison's disease in the conventional world, but really the body, it's not an all or nothing. It's not black or white. It has this shades of gray, really, where the body is trying to optimize itself the best it can, but then sometimes it has to almost hinder some of our hormone responses to reserve the response for when we really need it the most. So we might be literally running on fumes most of the time, for those patients that have adrenal dysfunction, even though they don't typically will diagnose as Addison's, which is an autoimmune condition of
Right.
severely low cortisol levels.
And
So,
that's typically what I see with conventional medicine. They'll look for the extreme ones, just like with Chinese medicine, we say blood deficiency, but you can't see that on labs. And a really, really severe blood deficiency is anemia, and that's when you can actually pick it up in
yes.
Western medicine. So it's interesting because things will be looked at in a much more drastic way, whereas functional medicine, even like when I do Dutch test, I know exactly what you're talking about with the cortisol flatlining where it's supposed to actually increase. It's something that is necessary in the body, but in its
Mm-hmm.
own rhythm. It has to have a rhythm and then
Yes.
lower later on at night. And it has, just like anything, a rhythm. Do you see circadian rhythm disruption as something that is common with some of the patients that you see that don't ovulate or have PCOS?
Oh, absolutely. And I feel like this is one of the areas of research that I've been really interested in lately. And I'm so excited for more advances in this area because I've just been so fascinated with the circadian rhythm lately. And so absolutely. And as it pertains to specifically to, let's just say, anovulation, hypothalamic amenorrhea, for instance, um, I don't want to get too in depth, but so when we're exposed to that morning sunlight, you know, our ancestors, they woke up with the sun. They were usually generally outside or close to outside. The light, hit their eyes through their retina, told their brain, okay, we have this light. And so that's when the diurnal patterns come into play. And so the cortisol level rises, and we have all these different, fluctuations in hormones to kind of get our day started. And then in terms of cortisol, it is supposed to kind of decrease towards the end of the day. But the interesting hormone that I've really have loved to learn more about is melanocyte stimulating hormone, and it's MSH. It's a hormone that is secreted from the pituitary gland, and it does actually rise in the morning and kind of levels off usually in the afternoon. And it's one of those hormones that ties along with the light and dark rhythm as well. And so MSH, I'm sorry, I think I got that backwards. MSH is low and then it goes up in the afternoon. So the reason why it's low in the morning is because it actually stimulates appetite. So when the levels are low, that means that we need to eat. We're hungry. So it stimulates that appetite. And then when it goes up in the evening, means we're satiated and we don't need to eat. And so for women that have hypothalamic amenorrhea, and this is something that I've just noticed clinically, they often tend to have lower melanocyte stimulating hormone levels in the morning and in the evening, because I've tested, both times of days. And it's just very interesting because that's telling me that the body is trying really hard to get this person to eat. So when those levels are so low, it's trying to stimulate that appetite. And so I don't know, specifically if the melanocyte stimulating hormone, what the role in ovulation that it plays, but I just find it so interesting because it is part of that circadian rhythm. And I do see a correlation with, imbalanced levels in that area and satiety, and, ovulation just clinically in practice. But
It's
yes,
so
and then of
interesting.
course, Yeah, it really is. And like I said, I'm so excited for more research on it. But as far as PCOS, I definitely see some disruptions in ovulation with women that have circadian rhythm. I call it dysfunction. And a lot of times I'll look at that cortisol curve and the cortisol awakening response. How quickly and how high is that cortisol going up in the morning? And is it going down appropriately? And a lot of times when you are speaking with these women, they're oftentimes will tell you, oh, yeah, well, my sleep is disrupted and, I'm going to bed late and I'm getting up, early or later. And it just kind of seems like it's not correlating with the light and dark patterns that our bodies were supposed to be, waking up and going to bed with. And so I have definitely seen that clinically for sure.
Yeah, it's really fascinating. I kind of feel like the menstruation is like a woman's pulse. The overall pulse, it's like a rhythm, it's a pulse. And nature has a pulse, a very strong pulse. And we do tend to get pulled. And sometimes we need to work extra to kind of sync with that pulse. When we
Mhm.
do, it actually helps everything else. And it's fascinating. I mean, it's such an interesting study. Another thing that you mentioned that I find fascinating is inflammation. Talk to
Mhm.
us about what you do. What are some of the ways that you work on lowering inflammation? I like the fact that you said you're optimistic about it because you know that you can do it.
Yeah, yeah. And if you were to have asked me that back in 2014 when I was not trained as a functional medicine practitioner, I would have been like, oh, well, see the rheumatologist, just because at that point in time, I didn't have the tools in my toolkit. And I often think back to some of these patients that I've seen years ago. And I'm like, wow, like I really could have helped that person if I knew what I know now. But, it is what it is at this point. So I can only move forward and help the people that I'm helping now. But with inflammation, it's just a loaded topic because there's so many different things that can cause inflammation. But from a general kind of standpoint, my patient population, a lot of the patients that I see are fertility patients, and so I'm often looking for reasons for why they can't conceive, and I will usually always do like a little inflammatory basic panel to start with, which would usually include a ESR, the erythrocyte sedimentation rate, a CRP, a C-reactive protein, the quantitative and the specific marker. Those are the kind of the three that I'll usually always look at. I do consider homocysteine a marker as well, which is kind of like this indicator of how well we're methylating in a way. And when we have poor methylation, this level can kind of build up. If you can think of it as like it's gunky, it's not methylating well. You're getting backup,
So
and that can.
methylating, so almost just for the late term, it's
Mhm.
more like your ability to metabolize.
Yes, and to metabolize and utilize these nutrients that you're taking in. And so I'll usually run a panel of those four, and then sometimes those levels come back normal. Um, but I'm still thinking that this individual could have inflammation. And so I might dig a little deeper. I might look at the gut. My favorite thing is to look at the
Yeah,
gut.
it's
So
huge.
yes, I find that a lot of women that have ovulatory disturbances often, maybe almost all of them that I've seen, honestly, have some sort of, gut dysfunction. So, um, what that means is we can do a comprehensive stool analysis and we're looking at their microbiome, their the quote unquote good bugs and the bugs that are opportunistic, the bugs that are pathogenic, and we're just kind of looking at this ecosystem within our intestines. And so, if some of these levels are off, if someone has an overgrowth in some of these opportunistic bacteria, that can create a lot of inflammation in the body. And then you can also look at something which I think a lot of people now are hearing of the term leaky gut, which is it's almost like a intestinal hyperpermeability. We do want our intestinal lining to be somewhat permeable for things to pass through, like with nutrients and things that we're ingesting. We want phytonutrients, chemicals that are from food to enter our bloodstream, but we don't want it to be so permeable that it's letting in, antigens and these large proteins or bacteria or viruses, and that's going to trigger our immune system. So if someone is having what we would call leaky gut, then that's a huge red flag to me. If someone has those markers of what we would see as elevated zonulin, which isn't the only marker, but it's just the one that is most well known at this point. If that's elevated, that's, definitely a search for, what's causing this inflammation. And yes, that leaky gut could be the sole reason for the inflammation, but oftentimes it's not. We have to think, well, why do you have leaky gut? And then so you're continuing to work upstream. Does this individual not have good digestive enzyme output? Maybe they don't have enough bile acids to, break down their food, the fats. And then that's irritating the lining of the intestines and disrupting those tight junctions between cells and letting things inappropriately into the bloodstream. And the way I see inflammation is an immune response, right? So when the body, the immune system is sensing something is off, it releases this cascade of an immune response. Histamine, leukotrienes, and so many different chemicals are, responsible complement factors for this immune response. And the body's trying to protect us. But if we are having this immune response every day, all day, then that's going to create this soup of inflammation in our body. It's just, we're not supposed to have, this immune activation 24/7. It serves its purpose for when we do encounter an infection of some kind or, what have you, but to have it turned on all the time is problematic for our health. So it can kind of be an overwhelming topic for some if you're trying to figure out causes of inflammation. But to kind of boil it down, I definitely look at, what's driving the immune system. Gut health for sure. Looking at these basic markers of inflammation, definitely, I would say starting there and then starting from those points and then kind of moving outward or moving up. So if I don't find what I'm looking for, then I might get a little bit more intricate with my testing. But generally, starting from there is, usually I'll always find something, and then we can work on that. Some of the easy hitters that I would say. Dental hygiene.
Oh, yeah.
I can't tell you, and that's, I guess, part of the microbiome, but in a way, but I just can't tell you how many times I see women, especially younger women, that, they just don't think to go to the dentist. I mean, they've always had good teeth, their teeth are white, they floss, there's no issues, but really, if you're not getting, that dental cleaning every 6 months, you can have plaque buildup, which can then harbor bacteria, and if you think of medications, tinctures, you absorb that in your mouth under your tongue. If you have this bacteria in your mouth all the time, this harmful bacteria, then you're going to be absorbing it into your bloodstream, which is then your immune system's going to set off and it's going to trigger this inflammatory cascade. So I feel like that's an easy one. It's always in my intake. Do you see a dentist every 6 months? Like, are you flossing? Are you brushing your teeth? That's a very easy one. But honestly, I oftentimes will see a good chunk of individuals that it's just not on their radar at first. They're not thinking that. And then once we, get them on a every 6 month regimen, like that inflammatory marker, which specifically the one that I see often is that CRP HS, the high sensitivity C-reactive protein, will drop significantly. And it's really satisfying when that happens.
Oh, yeah.
Yeah. So that one's a very easy one that I will always ask first, but there's so many things that can cause inflammation. It's just really important to, see a provider that is well versed in all the different, causes and, how to get from one point to another.
Definitely. I get excited about the supplement Megaspore Biotic. I've seen a lot of amazing results with that.
Yes, I have too. I use that. Probably that's the one that I use the most.
Yeah.
And it's great for the intestinal barrier, for strengthening that intestinal barrier and healing leaky gut. And if someone has SIBO, small intestinal bacterial overgrowth, I love, the spore base that it doesn't affect those patients. Than, versus like a regular Lactobacillus bifido strain would. So yeah, I couldn't agree more. I love that supplement.
Yeah, it's so great. I've seen it also lower inflammation. And one of my patients had rheumatoid arthritis. That was a big one. And she had really high inflammatory markers. And they wanted to get her on the medicine. She was pregnant and she went to the rheumatologist. And he said, "You're in remission." I mean, based on
Oh,
the markers, it was incredible.
that is incredible. Oh, that's so wonderful to hear.
Yeah, for sure. Well, I love listening to you because you have such a great way of breaking this information down.
Thank
Because
you.
it's really, there's so many levels and so many pieces, and that's the thing. We're such, our bodies are intricate and they have everything affects everything. So it's really important to keep all of that in mind. And then some of the causes that you've seen of high adrenals, have you noticed like there's certain causes that cause that to happen?
I would say that sleep disruption is very common, and usually the one that I will ask about first and address first. And sometimes it's the chicken or the egg situation too. Is the high stress hormone profile, is that influencing the poor sleep, or is it the poor sleep that was first? But I always try and attack that first. Sleep is just so important, and another area of research that I love so much. But getting that good quality of sleep, getting enough, and the quality is just so great for the body, and it's so healing, and that alone can definitely lower inflammatory markers as well in someone that is truly sleep deprived. But yes, I've done trials with women, where we've really kind of focused, and men too, but really kind of focused their attention to their sleep hygiene, getting a good regimen going. And the only thing that we've done, like we're not doing supplements, we're not doing anything. We're just focusing for a month or two on this sleep. They're going to bed the same time every night. They're doing the exact same thing every night. They're waking up the same time every morning. The cool, dark room, having a fan on if you need, or a white noise if you find that therapeutic. Doing a little meditation or stretch before bed, something that, that works for that particular person, we're trying to find. And then testing their adrenal profile after that, like once they've kind of gotten this regimen of sleep down, it's amazing that how much it can turn around in just a month or
Incredible.
two.
And
Yeah, so
that's all
that's
part of the circadian rhythm. It's part of that same
yes.
rhythm. And I like that you said every single night, having the same time, because you're
Hmm.
creating a rhythm where your body's expecting it. And actually, the more you do it, the more easy it'll be to fall into it because your body's expecting it.
Absolutely. And I think about this, with individuals that have like young children, they put their baby to bed every night at the exact same time. And if they don't, they're like, oh gosh, now my baby's going to have a terrible night's sleep, because they're an half hour later. Well, adults aren't different, like we also thrive on having that consistency as well. And, just because we have a little bit more autonomy in our choices in our day, I think that's somehow kind of goes to the wayside at times. But just trying to drive home that point of sleep, is critical. And like you said, circadian rhythm, it's just so important. I also like to layer in, same time to go to sleep, wake up, and then if you can, trying to get morning sunlight, going outside, watering your plants, doing whatever you want to do, grounding, getting your feet in the
Grounding.
grass.
Yeah.
Yes. Just 5, 10 minutes, the literature has shown that you can have significant increases in your cortisol. So to a healthy level, it's not going to
Right,
overspike
because you
you.
wanted that in the morning to increase. That's what gives you the
Yes.
energy. And then you want it
Yes.
to decrease at night. So cortisol is not a bad thing, just so
It's
people know.
not.
Yeah.
You want it high at the right time and low at the right time. And the interesting thing is when cortisol is high, melatonin, our sleep hormone, is inversely related. So that high cortisol in the morning tells our body to make high levels of melatonin at night. So, by trying to get into that rhythm of the
The yin and
sleep.
the yang. There you
Yes,
go.
yes, yes. So, by doing the morning sunlight, and I understand it can be very tricky sometimes, to get out there, especially, people in colder climates or winter time. They do have light boxes available.
Yep.
So you can get a little light
And they
box. You
have
can
grounding mats as
grounding
well.
mats, yes, yes, and grounding sheets and, all kinds of stuff. So there are definitely ways that you can, biohack your way through that if you can't go outside and get the natural sunlight, the grounding. And so, so yeah, I just love starting with that. But aside from that, adrenal dysfunction, some of the more intricate cases I would say would be stealth infections. If someone has Lyme disease or if they have even like a toxic mold exposure, that can really be driving their cortisol and throwing off their adrenals because the body is trying to compensate for this pathogen, this toxin that is invading the body, and so it's putting the pedal to the metal. It's trying to, get every little bit of help to the body that it can. But, like we said, having cortisol high all day long is not a good thing. So if I'm finding that someone is almost refractory to my initial lifestyle interventions, and our basic panel, we've addressed, I'm definitely kind of looking deeper into stealth infections and toxic exposures that can definitely drive those. And they can be a little bit more challenging to treat for sure. But if you can identify it, then, that's honestly half the battle. And then, you kind of hopefully can go a little bit uphill from there. But that I would say would be kind of my more challenging cases with adrenal dysfunction. And to be honest with you, I feel like toxic mold exposure is so prevalent, at least where I live in Maryland. I mean,
Mm-hmm. It's
there's a lot
very,
of
very
women.
hard to avoid. It's
It
really hard to
is.
avoid. I live in
Mhm.
Miami. We've had leaks, and so it's so hard to avoid. I wonder if there's a way that you can also protect yourself, where
Mhm.
your body's able to get stronger. It's almost like developing an immune system to it.
Yes, and that is, I think, the fundamental like part that that's how I like to treat stealth infections and toxic mold exposure. Is not like I'm not the type of provider that's a heavy hitter with antibiotics and things like that. Sure, I'll definitely treat, a Lyme disease appropriately as needed, but it's not all about, the antibiotic, the herbs. It's about strengthening the body
Yeah.
and allowing your body to essentially fight it off and heal itself. Our bodies have that innate ability to heal. You
Yeah.
just have to remove those barriers, that is
Yes.
inhibiting the body to do that.
100%. I feel like that is way more empowering because I've seen people like it has like destroyed their lives because they start to get, it's almost like an OC, you start to develop an OCD against mold, just like you do with like bacteria. It becomes like such this thing that you want to battle. And then I think to myself, it feels so much more empowering when you work on your own body's defenses.
Yes. Absolutely. Yeah. And just on a personal level, I actually dealt with toxic mold exposure. I identified it in 2020. And at the time, I was having longer menstrual cycles. I was not ovulating until, cycle day 20 something, and it could be irregular. I was like, what is going on? And then
Hmm.
finally, we found this toxic mold. We removed it. I worked a ton on my immune system, and now I'm, back to my normal 30-day cycle. So it's amazing, and just side note about this melanocyte stimulating hormone, mine was like in the toilet. It was so low. And
Hmm.
so that can happen with certain toxic exposures. But just another clue is, how the body, how all those hormones are so intricately related, and just the cascade, if one is off, that can kind of shut down the whole process.
Yeah,
So,
no doubt. It's crazy. There's so
mhm.
many, like everything affects everything. This is amazing information though. Wow, I could like, we could keep talking on and on because there's
Oh yeah.
so much. And that's the thing with fertility medicine in general. It's just so, there's just so much reproductive medicine. And so if people hear you, which I'm sure they're going to be fascinated by what you've said in this episode and want to find you, work with you, how can they do that?
Sure. Yeah. So I love to live on Instagram. I try and post there as often as I can, which is at vital.aspirations. And I am currently trying to open my own little micro practice in Maryland. So um, I also am on the website of www.vitalaspirations.com as well.
Awesome. Danielle, thank you so much. This was really, really great information and you just explained it beautifully. So really thank you so much for coming on today.
Thank you so much for having me. This was such an honor.
So that concludes today's episode. You can find all of the links mentioned on the episode notes. If you're enjoying these episodes, please take a moment to share and leave a review. Reviews mean everything to podcasters, and I really enjoy hearing from my listeners. You can also find me on my website at www.thewholesomelotus.com or email me at info@thewholesomelotus.com. I love hearing from my listeners. If you're interested and want updates as well as a free ebook on my top 10 fertility boosting habits, you can visit my fertility page on www.thewholesomelotus.com. I thank you so much for listening in and hope that you have a beautiful day.